first up for the rest of the afternoon will be Dr. Matern. He is a professor of laboratory medicine, medical genetics, and pediatrics, and co-director of the Biochemical Genetics Laboratory at the Mayo Clinic in Rochester, Minnesota. He has a primary interest in the biochemical diagnosis of inborn errors of metabolism, particularly lysosomal disorders, mitochondrial fatty acid beta oxidation disorders, organic acidemias, and amino acidopathies. Today, he'll be speaking on newborn screening for Krabbe disease, updates, and improvements.
Thank you, Margie. I hope you can hear me. Thank you to the Hunter's Hope Foundation for inviting me once more to talk about newborn screening and Krabbe disease and give you a few updates and maybe some thoughts about improvements. Although at this point, as you heard from the previous discussion, they're fairly marginal. So if I can move this forward. Here are my disclosures. I get paid every other week from Mayo Clinic, and that's really nice. I don't get any extra money for doing more or less newborn screening. So there's no extra incentive. And then you can see all the various committees and work groups I'm an unpaid member of. So you already heard that apparently newborn screening for Krabbe disease has been going on. If you want to add any other condition, you can go to the advisory committee and nominate a condition. And that happened for the first time, as you all probably also know, although I see there's more than 100 people online. So maybe some of those don't know that in 2000, the Hunter's Hope Foundation first nominated Krabbe disease for the recommended uniform screening panel. So this was, as you also heard, 1.5 years after New York had already started screening. So there were some data, and those data were reviewed through an evidence review. And in February 2010, Jackie Wagner received a letter from the chairman of the committee, Dr. Howell at the time, that they felt that there was not enough evidence yet to add Krabbe disease to newborn screening because there were questions about the condition itself, in particular early infantile Krabbe disease, the testing, not only in terms of screening, but also how do you confirm a diagnosis when there is a presumptive positive, and then what is really the best treatment and how good is it? New York was very honest in what they were doing, and in 2016, a paper on the first 8 years of Krabbe screening in their state. This is one of the 2 papers that came out in the same Journal of Genetics and Medicine, where Joe was the primary author, kind of approaching this task from the laboratory side. And again, they were very honest in their data that they provided, indicating that the positive predictive value of screening for Krabbe disease was only 1.4%, meaning only 5 out of 346 possible babies with Krabbe disease actually had the disease. So the other surprise from New York was that the incidence or frequency of Krabbe disease was only 1 in 1,000, when any paper before with estimates suggested it would be at least double that number. The way New York has been screening for the longest time was by using the tandem mass spectrometry-based enzyme assay and then setting a cutoff for when to either report it out as positive because the activity is really, really low, or doing as a second-tier test, DNA testing and looking for pathogenic variants in the GALC gene. Now, few words about the molecular genetics of Krabbe disease. So I mentioned already the enzyme is called GALC for galactocerebrosidase, which also describes the enzyme that's deficient. The gene has been well described initially by Dr. Wenger. To date, or at least on July 15, so a few days ago, there were 990 variants listed in ClinVar, of which only 179 are known to be truly pathogenic, and the rest of them is of either benign or likely pathogenic, of uncertain significance, likely benign, or has conflicting interpretations. And in the end, that leaves us then with 300 variants where we know what they mean, and 690 variants where we shrug our shoulders and have to say, could be disease, could be nothing. So that probably was the reason why the other paper describing the first 8 years of newborn screening in New York that approached it from the clinical outcomes perspective basically concluded that there are a lot of questions about Krabbe screening and that one should be careful as you consider doing screening for Krabbe disease. Nevertheless, as you also heard, there are currently 10 states screening for Krabbe disease in the US. There are no other country screening for Krabbe at this point, as far as the 10th state was Georgia, which started about 100,000 babies ago. They identified no case yet and had no false positives. They rely on enzyme and then primarily cyclozine. And they do this currently in a pilot study. These 10 states cover about 30% of all the babies born in the United States. So 10 states out of 50, but 30% of babies already covered. You can see here that there are several states that also had laws that passed, but the screening hasn't really started yet. And talking about my own state, Minnesota, there in April, the advisory committee voted to consider Krabbe disease for addition and is going through their own little evidence review over the next year. So we'll see what happens. These are the states that screen for lysosomal disorders. Also at this point, you can see there's some states that screen only for 1 and others already for 7 in Illinois. But why I'm showing this to you is because babies could be screened for Krabbe disease and they could be screened for fairly easily, because if you already screen for the 1 lysosomal disorder, adding Krabbe disease to that is not very difficult, as Dr. Gelb just indicated as well. Now, as you heard from Darren earlier, we've been involved in the actual screening since 2016, after a law passed in Kentucky in late 2015, and then they started sending samples to us on February 15, 2016. And ever since, we had the privilege of screening Kentucky babies for Krabbe disease, but also of Pompe, MPS 1, and then XALD as well. This is what we do. Also kind of answering the previous question about doing how difficult it is to add screening for ALD to the lysosomal enzyme screen. So we do a 10-plex assay that we published quite a while ago, where we basically take 2 punches. We use one to incubate for the enzyme activities, and the other one we extract the lysosomal leukodystrophy. Then that is being combined, and there's one analysis. So from an equipment perspective, it is all done on one system. What we do once the testing has been completed, we evaluate the results for these 10 6 activities and 4 lysophosphorylcholine concentrations using CLEAR, which is a bioinformatics tool that basically asks the question whether any of the babies on a specific run could have Krabbe disease, MPS 1, Pompe disease, or adrenoleukodystrophy. So it basically tries to compare a metabolite profile, also taking into consideration the sex of the baby and the birth weight and the gestational age when present, to come up with a profile, and then comparing it to the profile that you would expect in a baby with Krabbe disease or the other conditions, or in an unaffected baby. And when we get an informative score for Krabbe disease, for example, then we do a second-tier testing. If there's no informative score, it goes right to a normal result. So we have second-tier tests for all of the conditions that we screen the Kentucky babies for. And what is a second-tier test? So some of you may not really appreciate what it is. It's really the idea that you reduce false positive results when you look at an analyte or an enzyme activity where there's overlap between the disease range and the control range. You do this after the primary screen, but you do not ask for a new specimen. You basically take a punch from the original blood spot And if the second tier screening result is normal, then it overrules the primary screen. So it's no patient contact to figure out what's going on. So how does it work again? In the birthplace, the samples are collected. They go to the screening laboratory. They take their punches for the primary screen. And if it's normal, everyone's happy. It goes out as normal. If it is abnormal, what we do not want is that you basically go back and ask for another blood spot and do the same thing over, which only means waste of time. And when it comes to conditions like Krabbe disease, that is really important. So what you do when you have a second tier test, you take another punch, you do the more specific second tier test, which is in most instances normal. And if it is abnormal, then you go right to confirmatory testing and allow for faster treatment. So for Krabbe disease, we use cyclozine that you heard about already. This is what it looks like. It's also known as galactosyl sphingosine. And the problem with it is that it is not good to have around because it destroys your neurons. The good thing is that you can measure it and therefore have an idea whether the patient has Krabbe disease or not. And you can measure it in all kinds of things, including dried blood spots. So we published this along with Joe years ago. Joe actually was the first one to show that you can measure cyclozine in dried blood spots. And at one of the Hunter's Hope meetings is where he reported it, and that's how I knew about it. And then we worked together to make it possible in a newborn screening laboratory. So here you can see how cyclozine works or may not work for all variants of Krabbe disease. So the green bar here are controls that do not have Krabbe disease. And here you see cases with infantile Krabbe disease, 49 cases, and you can see their cyclozine is markedly elevated. Late infantile Krabbe disease is also elevated over controls, but not the margin here. The difference between normal and abnormal is not as high. And here you have just 4 cases of juvenile Krabbe disease, and you can see there's overlap. So we do not expect that we can identify every single late onset case of Krabbe disease using this approach where we rely on cyclozine. But you can see that we can get rid of pseudos and basically carriers as well. So what we do then, we do cyclozine, and again, if it's abnormal, the screen is positive, and if it's normal, then the screen is negative. And again, we have other second-tier tests for Pompe, MPS 1, and ALD. The one for MPS 1 actually requires another punch to measure dermatan and heparin, and that also works for any other MPS condition. How have we been doing? So these are data from the beginning through May of this year. 341,925 babies from Kentucky were screened. You already heard we had 2 true positives for Krabbe disease. We didn't have a single false positive, and both of those had infantile Krabbe disease. Overall, our false positive rate is fairly good, but you also heard already that we did have or still do have false positives for Pompe and MPS 1, despite the second-tier test. We didn't have a false positive for ALD at this point and had 4 ALDs in 1 Zellweger case. So this is a story of the first case we had in Kentucky. The blood spot was collected on the 2nd day of life. On this 3rd day of life, it arrived in the Kentucky lab. And then on the 4th day of life, it arrived at our lab at the Mayo Clinic. We started the sample prep and the incubation. It's an overnight incubation, the way we do it. And then on Sunday, so the sample arrived on Saturday. On Sunday, we had an informative result. At that point, this was at the end of the first year, so end of 2016, we still repeated the enzyme assay just to make sure, and we initiated the second-tier testing, cyclozine, and Kentucky was really eager for us to also do something molecular, so we also do the 30 kb deletion very quickly. And on Monday, we found that the enzyme was still very low, cyclozine was markedly elevated, and the 30 kb deletion was not present. So we did initiate immediate follow-up on Monday morning, and that was the 6th day of life. And the patient was admitted at Duke in the early morning of the 7th day of life. And then Dr. Kurtzberg and her team initiated not only the confirmatory testing, but also the preparation for a bone marrow transplant family wanted to pursue that, which they did. On the 9th day of life, we had the diagnosis confirmed by very low activity in leukocytes, by cyclozine being still elevated in blood spot and also in CSF. And the genotype, however, I would like to point out, included a variant of uncertain significance, which today is not considered of uncertain significance anymore, but at the time, that basically was a genotype of uncertain significance. On the 24th day of life, the baby received a bone marrow transplant, and I do not believe the baby would have received that on the 24th day of life did we not have cyclozine. And indeed, with a genotype of uncertain significance, you could argue that it may have taken much longer to get the transplant. There he is still at Duke on the 100th day of after the transplant. And here he is at 2 years old and at 4 years old. Cyclozine, we haven't measured it in a long time, but had not normalized by 2 years, but certainly dropped quite significantly. And he's making slow progress and certainly can be considered a happy camper. And if we were at the meeting in person, maybe you would run into him. So maybe next year. This is our second case, similar story. Baby was born, sample was collected and arrived at Mayo. This was on December 30th, and on December 31st, we had an abnormal result where, again, cyclozine was elevated. The 30 kb deletion was not present. We informed our colleagues in Kentucky, which we were concerned we might not reach anyone on New Year's Eve, but they were around, and the baby was referred to the University of Kentucky on New Year's Day. On the 8th day of life, the baby was admitted to Pittsburgh, where the diagnosis was confirmed, and the baby received a transplant on the 30th day of life. And again, the genotype was not straightforward, pathogenic, but also included a likely pathogenic variant. So there is the baby in the hospital, and now 7-month-old, also seemingly a much happier camper than any baby with infantile Krabbe disease would be at this age. So how is newborn screening? Well, you already heard it, this is a summary again for us. We have no false positives, 100% positive predictive value, frequency of Krabbe disease about 1 in 170,000. We did the second tier test 92 times, or at least the cyclozine. We actually don't do the 30 kb deletion every time because it really doesn't help, as you have seen. So we do it about in 1 in 3,700 babies. We have to do the cyclozine, which, if you think about it, to do a high resolution assay rarely is very expensive, but we're happy to do it. So it can be done efficiently, screening for Krabbe disease, and also effectively, but we're not quite there yet. So these are based on data from last year's symposium, and you can see what was reported from the States at the time. No one, unfortunately, comes close to 100% positive predictive value last year. And this, unfortunately, changed, as you just heard. So these are data from today, and we don't have the exact data for every state. But what I think is worth pointing out, which also the discussion already alluded to, that if you don't have a second-tier test, and that is apparently also true for New Jersey, although they had more luck at this point, with the baby screened, you just don't fare as well. And I would like to say, well, I think the evidence suggests that cyclozine actually makes a huge difference. If you just look at data from New York, and I greatly appreciate Joe for sharing that information based on last year and this year, and you look at the difference. So since last year, they screened 300,000 babies. There were 10 that were positive, 1 true positive, and 9 false positive. So the false positive rate is going down in New York. So that's great. The positive predictive value is getting better. And what happened? So on the one hand, certainly thanks to New York, the variant interpretation has been much improved. We know much more now about the gene than we ever knew before. And again, this is primarily because of New York. And then, of course, the use of next generation sequencing, where we find more and more people that carry some kind of GALC variant. Also, New York has started to use CLEAR. And as you heard, they're also starting really to pay more attention to cyclozine. Now, can cyclozine alleviate all the genotype problems that we see? So let's just look at one example, one of Joe's favorite, the PY319C variant, because that one has conflicting interpretations. We look at the minor allele frequency is 0.14%, and in some South Asian populations, almost 1% of the general population carries that variant. So it's really not that rare. It may result in a misfolded protein, therefore causing lower GALC activity. And unfortunately, there are a few patients that have been described recently by Dr. Escolar's group that are homozygous for this variant, who developed symptoms at 3 years and older. So maybe that's a variant we need to pay attention to. Now, looking back at the data that we have collected over the years, these are all cases, 8 cases that are compound heterozygous for the variant and a pathogenic variant. And you can see the cyclozine in blood spots and in red blood cells was basically elevated in all except for this one. This blood spot was taken at 27 days old, which in my opinion, problem, because we know that in blood spots, cyclozine goes down after the first week of life, most likely because of the physiologic change in hematocrit that goes down in that time frame. The red blood cell cyclozine was just at the cutoff of 5, so not completely normal. So does that mean this patient will have Krabbe disease at some point or develop symptoms of it is uncertain. But again, these are certainly highly suspicious. And I think if you have the variant and the pathogenic variant, your risk is very high. If we look at cases that are homozygous for the Y31C, 319C variant, usually also carrying other variants, such as particularly the D248N. And again, these don't all have elevated cyclozine in the blood spots. The ones we were able to test all had elevations in red blood cells. And I think these patients are at risk of developing Krabbe disease. Now, would a case like number 13 here develop Krabbe disease? I don't know. I don't know if the genotype limited to GALC is really informative enough. And what I think is that there are things that we don't know yet about the genomic makeup of ourselves to say that we really cannot exclude that there are other things that impact the development of symptoms. The patient number 20 here is the only one among those who has another, is homozygous for another variant that is considered a modifier variant. And this patient actually developed symptoms at 3.5 years old when the brain MRI showed signs of Krabbe disease. So that patient has been transplanted. And all the other ones have this other variant that is considered a pseudodeficiency variant. Finally, cases who are just heterozygous for the Y319C variant plus other pseudodeficiency variants, they have completely normal dried blood spot cyclozine levels, and I don't believe that they are at risk of getting any type of Krabbe disease. So we also published this paper talking about cyclozine and its role, and also came up with this algorithm as to what to do in the screening laboratory and then follow up. And here you can see that we divvy up cyclozine and elevated, intermediate, and normal. And our cutoff that we use is 2.0 in the newborn screening blood spots. Everything above 2 is considered abnormal. Between 2 and 10 is intermediate. And greater than 10 really requires immediate follow-up. I think this part here is the responsibility of the screening laboratories. So Kentucky, if we would report to them a value of 5 in cyclozine, we would tell them that this is likely a late onset and would suggest this flow to pursue the follow-up of this baby. And in the other 2 cases that were way above 10, we recommended they immediately get the baby to a transplant center for counseling and follow-up. I would also like to let you know that the ACMG ACT sheets for Krabbe disease are updated. There are now 2 ACT sheets for infantile Krabbe disease and later onset variants, and there is an algorithm that you can find on the ACMG website. As you already heard, Krabbe disease has now been nominated a 2nd time. And I'd like to point out that it is not just a nomination of Krabbe disease to be added to the recommended uniform screening panel. It is more specific than that. It really suggests or recommends that when you add Krabbe disease, it is for infantile Krabbe disease as the primary target of screening or the core condition, and all the other variants of Krabbe disease would be secondary targets that we would like to identify, but that we don't expect to identify every single case because we do not want to continue with a high number of false positives. And I still believe strongly that being told that your newborn baby may have Krabbe disease and then you Google to figure out what that actually means is something we should avoid as much as possible. So in conclusion, newborn screening for Krabbe disease can be done in a timely fashion with very few, if any, false positive results using a biochemical approach. Molecular costs a lot of money at this point still, is time consuming, and as I showed you, rarely provides you a conclusive result. Cyclozine testing is necessary. You need to be careful that you use sensitive equipment to do it. And it will then identify most, if not all, late onset cases. And what I also would like to point out is that after a week of life, it's probably better not to follow up by cyclozine measurement in blood spots, but move on to another specimen such as erythrocytes. And with that, I would like to thank everyone in the laboratory and my colleagues, including our recent retirees, Dr. Raymond and Dr. Rinaldo, and welcoming Dr. Hall, who gave me the information about the Georgia outcome to date, and Dr. Schultz. And of course, our colleagues in Kentucky, Mike Gelb, Joe, Hunter's Hope Foundation, and the Legacy of Angels Foundation. Thank you.